Good morning, everyone. Today's seminar presentation is on lumbosacral plexopathy. Presenter myself, M. Shivakumar, and moderator, Dr. S. Sruthi S. Nair. Today's the topic will be presented under these subheadings: anatomy of lumbosacral plexus, etiology and clinical features, electrophysiology, and limitations of ENMG in the plexopathies, diagnosis of plexopathies, and clinical cases. Coming to introduction, we'll see the formation of lumbosacral plexus anatomy. They are formed by anterior rami of L1 S3, L1 S2, L1 to S3 roots from the lumbosacral plexus. This is the here we can see the dorsal root from the posterior horn and from the ventral root, fusing to form the mixed spinal nerve, giving posterior ramus and anterior ramus. The anterior rami of L1 to S3 roots form the lumbosacral plexus. Then posterior ramus supplies the paraspinal muscles and the cutaneous supply there. This is comprised of two distinct portions: upper lumbar plexus and lower lumbar plexus, lumbosacral plexus. And all the nerves in the lower extremities are derived from these. Here we can see L1 to S3 and with a variable contribution of T12 and S4. Lumbosacral plexus located within the psoas muscle space and the exit from the lateral border of the muscle. So it is commonly involved if psoas muscle pathology like abscess or any other pathology of psoas muscle. Lumbosacral plexus are involved because it is in the substance of psoas muscle. And coming to upper lumbar plexus, upper lumbar plexus mainly formed with the ventral primary rami of L1, L2, L3, L4 with some variable contribution from the T12 root. Here we can see this lumbar plexus. After the fusion, they've divided into anterior and posterior division, anterior, ventral or dorsal divisions. From anterior division, we can see this yellow colored iliohypogastric nerve, ilioinguinal nerve, genitofemoral nerve, and obturator nerve. These are derived from the anterior divisions. And the green color, the nerves which are in green color, the femoral and lateral femoral cutaneous nerves from the posterior division. I can see the root values here. Iliohypogastric and ilioinguinal mainly L1 and genitofemoral nerve L1, L2. Here obturator L2, L3, L4. Same L2, L3, L4 root division as same as root value, same as obturator, but femoral is from the posterior division. And lateral cutaneous nerve, femoral cutaneous nerve from L2, L3 of the posterior division. Nerves of upper lumbar plexus, as we already know discussed about the root values. Iliohypogastric nerve and ilioinguinal nerve motor supplies to transverse and internal oblique muscles, and sensory supplies of the iliohypogastric. You can see the small strip in the lower anterior abdomen, and ilioinguinal supplies along with the genital branch of the genitofemoral nerve, supplies the scrotum, mainly upper part of scrotum, and also skin over the inguinal ligament. This is coming to the supply of genitofemoral nerve. It is divides into genital and femoral branch at the level of medial inguinal ligament. Genital branch supplies the muscular supply to this cremasteric muscle and also sensation over the lower scrotum and labia. And the femoral branch supplies skin over the femoral triangle. This is the femoral branch. And here the genital branch. Femoral nerve, as we discussed, it is from the posterior divisions of L2, L3, L4. And it runs through pelvis and exit from the pelvis under the inguinal ligament. After that, it supplies muscles in the anterior compartment of thigh, mainly the quadriceps, which are formed by vastus group and also rectus femoris, and also pectineus and sartorius. This ilios and also iliopsoas before exiting from the pelvis, before crossing the inguinal ligament. This iliopsoas muscle mainly acts on hip flexion and the other anterior group of muscles on knee extension. So coming to sensory supply of femoral nerve, um, sensory branches are medial. So calf is supplied by the saphenous nerve of it's a branch of femoral nerve, and this is the sensory supply below the knee. Rest all supplies above the knee through medial cutaneous nerve and intermediate cutaneous nerve of thigh, which are both the branches of femoral nerve. So skin is supplied anterior part of middle anterior part of thigh and medial calf. Obturator nerve is formed from anterior or ventral divisions of L2, L3, L4, and it descends to the pelvis and exit through the obturator foramen and divides into the anterior and posterior branches. This posterior branch supplies adductor magnus, and all other adductor brevis and adductor longus and gracilis are supplied by the anterior branch. This is adductor longus, this is gracilis, and this is adductor brevis. This is pectineus, which is supplied by femoral. Sensory supply, as we know, it is supply small area of medial thigh here, like small area over the medial thigh, it is supplies. Lateral femoral cutaneous nerve of thigh, formed from the roots of L2, L3, and it's a pure sensory. Well, as we know, like it emerges laterally from psoas muscle and obliquely and comes under the inguinal ligament, where is a common site for injury and compression. It divides into anterior and posterior branches. It supplies us a skin over the anterior lateral thigh. Here we can see lateral femoral cutaneous nerve of thigh supplying the anterior lateral part of thigh. Here in this image, you can see the sensory supply of upper lumbar plexus. This is, as we already discussed, in a femoral. This area of skin is supplied with anterior part of thigh supplied by femoral nerve via its branches, intermediate and medial cutaneous nerve of thigh. And here, this is a supply. This is a sensory supply by femoral nerve via the genitofemoral nerve branch, femoral branch of genitofemoral nerve. And here in the medial calf, it is saphenous nerve. And coming to lumbosacral trunk, lumbosacral trunk is formed by the fusion of majorly L5 and some contributions of L4, and it descends to along with the pelvic brim, and it supplies some motor supply to the psoas muscle. Mainly, the importance of lumbosacral trunk is it gets compressed during the normal vaginal delivery and causing lumbosacral plexopathy. And also, it is in close relation with hypogastric vessels, lateral rectum, and pelvic colon and ureters. Involvement of these structures or any malignancies can also affect the lumbosacral trunk. Lower lumbosacral plexus formed from the roots L4, L5, S2, S3, S4. Same as upper lumbar plexus, we have the anterior division and posterior division. From the anterior divisions, tibial nerve and the pudendal nerve. Tibial nerve and pudendal nerve arises. Tibial nerve root value is L4, L5, S1, S2, S3, and the pudendal S2, S3, S4. Posterior divisions give rise to superior gluteal nerve, inferior gluteal nerve, and also peroneal part of sciatic nerve. From the both anterior and posterior divisions, there's a posterior cutaneous nerve arises. Sciatic nerve, after the formation by both tibial and common peroneal combined, it leaves the pelvis through greater sciatic foramen under the piriformis muscle. It supplies knee flexors, hamstrings, and also lateral division of adductor magnus. All muscles innervated by peroneal and tibial muscles And the sensory supply entire lower leg below the knee, except the medial calf, which is supplied by saphenous nerve. Here we can see from the foramen exiting sciatic nerve and supplying the posterior compartment of thigh, hamstring muscle, semimembranous, semitendinous, biceps femoris, and short head and long head, and later dividing into tibial nerve and common peroneal nerve. Where here the tibial nerve supplies the posterior compartment of a leg, supplies gastrocnemius, plantaris, soleus, popliteus, and tibialis posterior, flexor digitorum longus and flexor hallucis longus. All the posterior muscles of leg are supplied by tibial nerve and continued as down and supplies the muscles and sensory supply in the foot, mainly on the plantar surface. Then this common peroneal nerve, after dividing, it changes its course anteriorly and supplies the muscles in the anterior compartment of leg. Before that, it divides into superficial peroneal nerve and deep peroneal nerve. Here, the deep peroneal nerve mainly supplies the anterior compartment, deep muscles, tibialis anterior, and extensor digitorum longus, extensor hallucis longus, and peroneus tertius. These are the muscles supplied by deep peroneal nerve. Superficial peroneal nerve supplies peroneal longus and brevis. These are the muscles, peroneal longus and brevis by superficial peroneal nerve, and cutaneous supply of lateral leg by superficial peroneal sensory nerves of medial dorsal cutaneous branch and intermediate dorsal cutaneous branch, and the upper lateral leg is supplied by the branch directly given from the common peroneal nerve, lateral cutaneous nerve of knee. Here, this area supplied directly from the common peroneal nerve just before the division, and this is supplied by superficial peroneal nerve. And the sensory supply of a deep peroneal nerve is only the small areas near the first web space. Other nerves of lumbosacral plexus, superior gluteal nerve and inferior gluteal nerve. Superior gluteal nerve root value is L4, L5, S1, and inferior L5, S1, S2. Inferior gluteal nerve supplies gluteus maximus muscle. Superior supplies gluteus medius and tensor facial lata and minimus. And cutaneous distribution, posterior cutaneous of thigh, as we can see, lower buttock and posterior thigh is supplied by posterior cutaneous nerve of thigh, which is a branch of lower lumbar plexus. Lumbosacral plexus, lower lumbosacral plexus sensory innervation. This is a gist of it. Here we can see a lateral cutaneous nerve of calf from the common peroneal nerve, the upper calf, and the superficial peroneal nerve supplying the rest of the lower calf and also the dorsum of the foot, and lateral supplied by sural nerve, branch of tibial nerve. Sural nerve root value is S1. Sural nerve is formed from the two branches, medial sural nerve and lateral sural nerve, fused to form sural nerve. This is from the contribution is from tibial nerve and common peroneal nerve, medial and lateral fused to form sural nerve. Coming to lumbosacral plexopathy, it is an involvement from at least two different root levels and from at least two different peripheral nerves. So usually the plexopathy occurring in isolation is rare. Frequently occurs along with the involvement of roots and nerves, and causing lumbosacral radiculoplexopathies or radiculoplexoneuropathies. And this is more common in the disease like inflammatory or infiltrative, where they can diffuse involvement from roots, plexus, and nerves. In pure lumbosacral plexopathy, there should not be denervation of paraspinal muscles because these are supplied by the posterior rami from posterior rami from the roots, direct from the roots. Paraspinal involvement is present even with plexus involvement if radicals are also involved, like plexopathies, paraspinal muscle involvement can be seen. And when it comes to different syndromes of lumbosacral plexopathy, upper lumbar, lower lumbosacral, and plexopathy, of which lower lumbosacral is more than 50%. Etiology of lumbosacral plexopathies. This caused due to structural and non-structural causes. Structural causes are due to compression or else compression or any shearing stress during traumas. Here we can see the retroperitoneal hemorrhage secondary to anticoagulation or any patients having hemophilia, um, and pelvic or abdominal tumors and metastasis and radiation therapy during the treatment of these tumors. Aneurysmal compressions are mainly from common iliac artery and internal iliac artery, endometriosis, and trauma. Now, coming to non-structural causes, plexopathy can be seen as uh, inflammatory causes, and infarction is in vasculitis, and postpartum, as we discussed, compression, normal vaginal delivery, compression of a lumbosacral trunk and nearby plexus, and also diabetes can cause diabetic hemiotropy uh, by causing this lumbosacral plexopathy. Radiation and post-surgical, um, as during the surgery retractors are used, can cause a stretch injury. And clinical presentation of upper lumbar plexopathy. Lumbar plexopathies affect predominantly L2, L3, L4 nerves, as we discussed already. Upper lumbar plexus are derived from L2, L3, L4. So here, uh, as only upper lumbar plexus involved, the anterior compartment of thigh, and so the quadriceps are affected. There the patient will have a knee extension weakness, and iliopsoas supplied by the same upper lumbar plexus have is a, there. So there's a hip flexion weakness, and also adductor supplied by obturator nerve. It is also derived from the upper lumbar plexus. So thigh adduction weakness. So knee extension, hip flexion, and thigh adduction weakness. These are the presentation in upper lumbar plexopathy. Pain, patient can be presented with pain which is radiating to anterior. Sensory loss, uh, whole of the like anterior above the knee. Major sensory loss will be there above the knee, and also along the medial calf, because involvement of saphenous nerve, which is a branch of femoral nerve derived from upper lumbar plexus. Knee reflex is absent. Here, in pure upper lumbar plexopathy, ankle jerk is preserved. In lower lumbosacral plexopathy, which is predominantly affects L4, L5, S1, S2, S3 nerve fibers. Here, the weakness is due to, weakness of the is in hip extension, as gluteus maximus weakness is there, and hip abduction, which is by gluteus medius and tensor fascia lata, and knee flexion, hamstring muscles, and all movements at ankle joint, because peroneal muscles, tibial nerve and peroneal nerve are supplied. The muscles supplied by these nerves are affected, and also sphincters are affected. Patient presents pelvic pain, but also this pain to the posterior thigh. In upper lumbar plexus, the pain radiates to anterior thigh, and the lower lumbar plexus, the pain is radiated to the posterior thigh. Sensory loss, we can see in the posterior thigh and posterior lat of cuff and foot. Like posterior thigh, we have seen the supplies by the S1 root, and the posterior lateral calf also supplied by nerves derived from the lower lumbosacral plexus. Ankle reflex here is absent. Sometimes the nerve fibers distant from the peroneal nerve often preferentially affected. Even in lumbosacral plexopathy, patient can have only isolated peroneal-like presentation, which we can see also in sciatic nerve L5 root lesions. In sciatic nerve also, preferentially the peroneal nerve fibers are more often and more severely affected compared to the tibial nerve fibers, and also L5 root lesions also, peroneal nerve is specifically affected. Coming to clinical features according to the specific etiology, hematomas and other vascular lesions in retroperitoneal and pelvic area. These patients with having these hematomas presents with acute severe pain in groin and radiating to anterior thigh and lumbar region. Due to this pain, they hold the hip flexed and externally rotated. And mainly the femoral territory is predominantly involved in this type of causes. Acute pain, sometimes patient can present acute painless ischemic lumbosacral plexopathy without signs of limb ischemia, which can be seen in aortic dissection. Other causes are trauma, which is seen in only high velocity and severe injuries, where sacral fractures and sacroiliac joint separation. Such scenarios, we can see the involvement. Mainly, this is compared to the brachial plexus. Trauma is a less less commonly seen in the lumbar plexus, lumbar plexopathy. In infection causing any psoas of the psoas muscle or any adjacent peritoneal space causes compression to the abscess formation causes this lumbosacral plexopathy. Even the Pott's disease causing psoas abscess. Tumors is one of the most common cause of non-traumatic lumbosacral plexopathy. Patient presents with the pain in the lower back, thigh, and hip. This is peculiarity is the patient feels pain is exacerbated on lying down, but relieved by getting up and walking. Here, the lower lumbar plexus commonly involved. The patients with tumors, when they due to plexopathy due to radiation or else tumor recurrence. Here we can see the tumor radiation plexopathy. The onset of symptoms usually after 6 months to many years after the radiotherapy. The symptoms can be unilateral or bilateral, asymmetric, and usually the distal muscles are involved. Uh, Distal leg weakness is observed, and with pain only in 50% of patients. And this EMG can shows electrical myokymia, and also patient can have clinical myokymia, which is pathognomic for radiation plexopathy. Here, this should be differentiated from tumor recurrence, uh, uh, which can also be a possibility. Tumor recurrence, the patient have a marked pain at onset, and the involvement is proximal when compared to the distal leg weakness in radiation plexopathy. And here the weakness is unilateral, which is typical for tumor recurrence. Here it can be unilateral or bilateral. And paresthesias are uncommon in both in tumor recurrence and radiation plexopathy. Postpartum plexopathy, already we have discussed about the lumbosacral trunk, and it's seen in the like normal vaginal delivery. At risk are small primates and relatively large baby. And the prognosis is good recovery over the time. Diabetic amyotrophy, also known, these are various names of the diabetic amyotrophy, like Bruns-Garland syndrome, diabetic lumbosacral radiculoplexoneuropathy, and diabetic mononeuritic multiplex, diabetic proximal neuropathy. All these are names of diabetic amyotrophy. Classically involves upper lumbar plexus and nerve roots. Actually, diabetes it doesn't like radiculoplexopathy is more common than isolated plexopathy. At-risk individuals are mild and long-standing diabetes, type 2 mainly having a good control and with the good glycemic control. And this attack is induced during the patient trying for the losing the weight and starting of any exercise program and tighten their glycemic control. So here you have to observe that usually in those with good glycemic control only these patients, like this is more common. Presentation is severe, deep, boring pain in the pelvis and proximal thigh for around 6 weeks. And there is significant weakness, which is out of proportion with absent knee jerk and very little sensory loss. Because as we discussed, it is mainly involves the upper lumbar plexus to keep in mind. And here the peculiarity is the very little sensory loss. And prominent wasting, anterior and medial thigh, upper lumbar plexus, nerves derived from femoral and obturator nerve supplying the anterior and medial thigh. Prominent wasting can be seen. That's why it's called amyotrophy. And on nerve pathology, the main pathology is microscopic vasculitis, causing the nerve ischemia. Mostly, this is, as I already told, this mostly occurs unilaterally, may affect contralateral side within like after first few weeks and months of the initial Um, role of EPS and objectives of EPS in plexopathies helps in localization, characterize pathophysiology, and also establishing severity, chronicity, and prognosis, and planning the treatment. Localization, it helps in ruling out radiculopathies and multiple mononeuropathies. Like two important parameters are SNAP and paraspinal EMG. SNAPs, as the plexopathy is to DRG, SNAPs are absent, and paraspinal EMG, as paraspinal muscles are spared in pure plexopathies, the paraspinal EMG, if it is normal, uh, it is normal in plexopathies, and if it is paraspinal muscles are involved, then more likely it can be radiculopathy or radiculoplexopathy. Here we can see this is a normal intact without any pathology, where SNAPs and CMAPs can be seen. Here the lesion is proximal to DRG. Uh, Here, sorry, distal to DRG, where the snaps are preserved. Here, this is a scenario, proximal. Proximal to DRG, snaps are preserved. Here, the scenario like plexopathy, where DRG is disconnected, so the snaps are lost, and CMAPs also reduced, as in because motor are involved. This is a recommended protocol for lumbosacral plexopathy. TBL, like we study tibial nerve, peroneal nerve, and sural nerve, superficial peroneal, and tibial and peroneal F responses are recorded in H reflexes. If upper lumbar plexopathy is suspected, or lateral femoral cutaneous neuropathy, additional like saphenous nerve, bilateral studies, and femoral nerve recording from the rectus femoris, femoral nerve, and the lateral cutaneous nerve is also studied. EMG, we usually do at least like two. It's not a strict protocol, but recommended protocol is at least two peroneal innervated muscles and two tibial innervated muscles. Rest all one sciatic, one superior gluteal and inferior gluteal, and two femoral innervated muscles, one obturator innervated muscles, and paraspinal muscles of L2, L3, L4, L5, S1 can be done according to the clinical involvement. Here we can see in EMG denervation, evidence of denervation. Um, it is seen in more than one myotum innervated by more than one lower lumbar nerve. General electrophysiological features of LS lumbosacral plexopathy. Normal routine motor conductions are usually normal, except is reduced CMAPs, prolonged and normal FA latencies, and abnormal snaps are seen in lumbosacral plexopathies. Some reduction of the losses we were planning around this vacancy related to that. The law of the primary movement. They are not looking loss. Here, there are a few muscles of significance in EMG where they are crucial in differentiating different pathologies. The gluteal muscle, where helps in the differentiation of sciatic neuropathy from lower lumbosacral plexopathy, because gluteal muscles are supplied by the upper, like S1, where if its involvement is seen in lower lumbosacral plexopathy, but not sciatic neuropathy, because though sciatic neuropathy is from the sciatic nerve is from the lower lumbar plexus, it is supplied by the other superior and inferior gluteal nerve. So it is paired in sciatic neuropathy and involved in lower lumbosacral plexopathy. So when we have such scenarios, we can do this EMG of gluteal muscle available. Again, in the similar scenario, like if the differentiating of femoral neuropathy and lumbar plexopathy, thigh adductors which are supplied by obturator nerve involved in lumbar plexopathy, but in femoral neuropathy which is having L2, L3, L4, it's not, thigh adductors are not involved. Paraspinal, as we already discussed, differentiates radiculopathy versus plexopathy, where paraspinal muscles are involved in radiculopathy, spared in plexopathy. Limitations in electrodiagnosis. Bilateral lumbar plexopathy is difficult to differentiate from polyneuropathy. In such scenarios, upper limb extremity studies are helpful. Normal paraspinal muscles on EMG do not exclude a radiculopathy, though we have discussed till now that normal paraspinal muscles on EMG, it's only seen in does not exclude radiculopathy because in the process of recovery, reinnervation occurs earlier in the proximal muscles. So the muscle might have been reinnervated, or else there may be a fascicular sparing, sampling error, or difficulty in examining the paraspinal muscles due to poor relaxation. But only abnormal snaps can be able to differentiate a plexopathy from a radiculopathy. If lesion is acute, study may be normal because during first 10 to 14 days, denervation will not be seen. And first week, NCS also can be normal. Here's the table. Same, we have discussed how to differentiate from different closed EDs, femoral neuropathy, lumbar plexopathy, and lumbar radiculopathy. Here the snaps are normal in saphenous snaps are normal in lumbar radiculopathy, and thigh adductors and tibialis anterior uh, is normal in femoral neuropathy, and which are involved in both lumbar plexopathy and radiculopathy. And paraspinal fibrillations we involved only paraspinal muscles in radiculopathy. Here we can see differentiation of S1 radiculopathy, sacral plexopathy, and sciatic neuropathy, where we can see peroneal muscles and tibial muscles are involved in all radiculopathy, plexopathy, and neuropathy. But differentiation is possible. If paraspinal muscles are show denervation, it is radiculopathy, and denervation in gluteal muscles is not seen in sciatic neuropathy, as already we discussed this. And coming to clinical cases, case 1, a 52-year-old male, known diabetic and hypertensive for 10 years on medication, presented with 6 months history of insidious onset paresthesia over left anterior thigh, and 2 weeks later developed pain in the same area. 1 month into illness, developed paresthesia in both lower limbs, involving feet till mid-calf. After 5 months into the illness, he developed insidious onset weakness of both lower limbs, left more than right, had difficulty in climbing stairs due to difficulty in lifting the leg onto next step, difficulty in getting up from squatting position. There was no history of back pain or radiating pain, no history of craniobulbar symptoms, bladder or bowel involvement. Examination, tone and bulk are normal, reflexes, knee jerk and ankle jerk absent, rest reflexes normal. Coming to power, upper limb, abnormal, he is having weakness in the lower limb, hip flexion. It is 4+ on right side, 4- on left side. Hip extension 4+ and 4+. Hip adduction weakness on left side 4-. Knee flexion 4- bilateral. Knee extension right 4+ and knee extension 4-. And also ankle muscle weakness, where he's having dorsiflexion weakness and also plantar flexion weakness. Inversion 2 on right side, eversion which is severe on left side.
Long-standing diabetic is presented with initial sensory disturbance over left burst.
52-year-old male, long-standing diabetic, has presented with sensory disturbance over left anterior thigh. So that is in the femoral distribution. Then 1 month into illness, he has developed both paresthesia over both lower limbs involving feet till mid calf. So that is L5 distribution. Then in multiple radical peripheral nerve peripheral nerves. Then after 5 months, he has developed insidious onset weakness of both lower limbs, left more, that is difficulty to flex, bend, take leg into the next step. So hip flexion weakness. And he also has difficulty to get up from squatting position, that is hip extension weakness. Then from so at the presentation, sensory involvement in left, so that can indicate a plexus involvement. But later on, he has developed bilateral sensory paresthesia as well as weakness which involves multiple nerves. So peripheral neuropathy. Bilateral plexus.
Second is that there's a body neuropathy like symptoms. What is the differential diagnosis?
Sure.
In different neuropathy, like preservation rate.
It's some rapid progression is there, radicular neuropathy, radical distal.
That is your third year board examination. Can you pay body things?
Bladder is not now. Root pain, radiating pain is not there.
Some pain, but bladder is not.
So examination, upper limb is normal, lower limb, there is bilateral hip flexion and extension weakness. And there is adduction weakness more than abduction. And both knee flexion and extension are weak bilateral, and dorsiflexion, plantar flexion, in all muscle groups are involved bilateral. Symmetrical. Plexus pattern bilateral. Because asymmetric distribution of weakness is there. Both
Proximal
So on the left side, the flexors and adductors are big. And on the same side, the expression is weak compared to the opposite side. There is also distal weakness of the upper lumbar plexus pattern. There is also lower plexus, but that's
more in
on the opposite side. And what is one major point which is against radical neuropathy and examination?
So nerve conduction showing left median nerve amplitude is normal, latency is prolonged with normal velocity. There is no conduction block. Right median nerve amplitude is normal, latency is prolonged, no evidence of conduction block, velocity is normal. Ulnar, left ulnar amplitude is normal, latency is normal, no evidence of conduction block and normal velocity. Right ulnar amplitude is normal, latency is normal, velocity is normal. So upper limb there is bilateral median latency prolongation. Then lower limb, right peroneal EDB, distal amplitude is decreased with latency prolonged and velocity is on the lower side. Amplitude is reduced. Then right peroneal synapses are absent. Right tibial amplitude is normal, latency is normal, velocity is on the lower side, but not in demyelination. Then left tibial amplitude is normal, latency is normal, velocity is on the lower side. Then peroneal prox, there is poor proximal pickup and femoral, lateral femoral, left femoral, its CMAPs are non-recordable. Right femoral amplitude is reduced. So lower limbs, there is peroneal involvement and femoral involvement. Then F waves, the bilateral tibial reduced conduction velocity. So tibial is also involved. Then F wave, symmetric by both. Okay. Symmetric. Proximal involvement is asymmetric. Then F wave, upper limb, median nerve, right median nerve is prolonged. Left ulnar prolonged.
That is normal.
Left ulnar is normal. Lower limb by right bilateral peroneal is non-recordable. The tibial is prolonged. Then snaps. So right median is latency, peak latency, bilateral median is prolonged. Ulnar is normal. Lower limb snaps are absent.
What do you think is the process?
So upper limb also there is a median, ulnar is spared. Ulnar is spared, so bilateral median neuropathy is present, probably CTS. Then lower limb, there is involvement of both upper lumbar plexus as well as lower lumbar plexus nerves with the involvement of snaps with some asymmetric in the femoral. It post-ganglionic disease because snaps are absent. What is the evidence to say that this process is not avoided? So ulnar is spared. Ulnar is spared. Upper is spared except for possible CTS. CTS also covered by the transfer. That is not one which favors in proximal involvement is there. Femoral. Basically, that is there. Is there a supply for because since upper and lower parts are affected, all three will be lost. Maybe also steroids, urines, everything will be affected. Because both the levels of involvement is there. So there only one level in the southern to another one potential. Further it is a success rate.
For example, it's a case of lower plexus involved, you can show that something is being driven. The point is famous plexus point. So here, we need additional EMG person to confirm that there's no point.
In upper limb, there is the difference in latency between median and ulnar is prolonged in bilaterally, more in right side. So, because CTS is more in right. Then EMG is showing the fibrillation, spontaneous activity in right tibialis anterior and bilateral tibialis anterior. Then left rectus femoris reinnervation potentials are recorded. Paraspinal muscles are normal. So that is involvement of femoral nerve denervation and renervation is present bilaterally without paraspinal muscle involved.
This maximus has this.
Gluteus maximus has also reduced in okay. Left rectus femoris and left gluteus maximus. In the left side, both upper and lower plexus are involved. That is as asymmetric proximal muscles are involved and asymmetrically involved in left side.
That all we know is that paraspinal is one of them. But that actually it says as contributing better to the establishing asymmetry than EMGs. It could be because of one process. For the sampling error may also be there because everyone one area of the muscle. So if you do multiple muscles supplied by the same, but we will have both. So finally, what are the problems?
So there is an asymmetric left side upper and lower plexus and right side lower plexus pan plexus involvement, bilateral asymmetric, diabetic. So
Coming to case 2, a 70 years old male, known hypertensive and diabetic, presents with left lower limb weakness for 1 month in the form that he is not able to lift the leg above the bed and associated with dragging sensation and pain of thigh of moderate severity. He was not able to bear weight on the right lower limb. Because of this, he was not able to climb the stairs. No back pain or distal weakness or bowel bladder involvement. Able to walk with minimal support independent of ADLs. An examination, there is a wasting of over left anterior thigh and tone is normal, sensory normal, power. Here we can see the weakness on examination is weakness of left-sided flexion and adduction, hip adduction, hip flexion and hip adduction, and also left-sided knee extension weakness. Ankle muscle.
So this 70-year-old male who is a hypertensive and diabetes presented with left lower limb weakness for 1 month, which is subacute onset, and in the form of not able to lift his leg above the bed.
The bed and associated like he is not able to lift the leg off the bed.
So, and also there is difficulty climbing the stairs. So it is more of a hip flexion weakness. And
Very standard to the actually to like. Anti-grav in history. Severe and not
Okay. So otherwise, no back pain and distal weakness, bowel or bladder.
Very low. Very strong.
Left leg. It's left leg.
Okay.
The weakness is not there in right side.
So he's able to walk with minimal support and independent of all the ideals. Examination, cranial nerves are normal, but there is wasting of left anterior thigh. Tone is normal, sensation normal. Power upper limb is normal. Hip flexion on the left as well as hip adduction is weak. And along with that, knee extension is minimally weak. So this is going beyond the upper trunk.
You?
Upper trunk, because hip flexion is weak, adduction is weak, and
Even-
so upper trunk is in upper lumbar.
It cannot be seen.
Knee
Excess
ex-
of-
Okay, so upper trunk,
Lumbar plexus.
lumbar plexus. Okay. So upper. Femoral adduction, adduction weakness is there. Knee jerk and ankle jerk, it is preserved. But it is okay, so left is affected. So nerve conduction study, upper limb bilateral median ulnar is normal, and coming to lower limb, peroneal latency is prolonged and amplitude is also reduced bilaterally. Velocity is also reduced on the left. There is mild asymmetry, left more than right, and tibial latency and it is normal. Amplitude on the left, it is slightly reduced, and velocity is normal. It is not asymmetric, but it is mildly reduced. And peroneal is not asymmetrically reduced, ma'am. There is 50%.
What is the significance of the recipe? This person is more very innovators. Unless of course, it's a huge seriousness.
Okay.
So it is more important also to see what is the process, because there is also estimate. Also, there's also estimate, the relevance is very.
So there is proximal pickup, but asymmetry is not there.
That's the bones touch.
Mhm. Yes. And but in the femoral there is asymmetry. There is amplitude is more reduced on the left than the right. And right peroneal FA is absent, but tibial bilateral tibial it is prolonged. So
Peroneal also, left
left peroneal is also prolonged. So sensory, superficial peroneal and left, that is lateral cutaneous nerve is also absent. Bilateral sural is also affected. So lower limb bilateral sural, superficial peroneal, as well as lateral femoral cutaneous is affected. No? Saphenous is also absent. So in the nerve conduction study in the CMAP, there is asymmetry between the left as well as the right. For peroneal as well as tibial. Tibial not significant. So peroneal, there is asymmetric involvement of the left more than right. And femoral is also affected on the left. So left femoral and peroneal is affected. Bilateral femoral. And sensory, bilateral sural, superficial peroneal, and lateral femoral cutaneous is affected. All are. So upper lumbar plexopathy. Bilateral.
On the left side.
Yes.
Is there evidence for that?
Yes. Just that.
What is the evidence?
Because all the sensory nerves are also affected, like lateral. Lateral femoral cutaneous.
Snaps are absent. Snaps are absent.
So bilateral. Okay. Superficial. Okay. Left femoral is absent. Asymmetric. Flex.
Addition there. Addition. There's a possible polyhedron. And that also goes with that representation of the person.
Okay.
Sensory examination is normal, that's what's happening.
Sensory examination was.
So EMG.
Okay, so in EMG there is renervation from left tibialis anterior, then active denervation as well as renervation from left rectus femoris and adductor magnus. So paraspinal as well as gastrocnemius is normal bilateral. None means nothing, no?
That is normal.
So gastrocnemius bilateral is normal, along with paraspinals are normal.
So what is your final diagnosis?
So left upper lumbar flexible.
In addition, what else?
In addition, peripheral neuropathy.
Sensory and motor system.
Next case. A 49-year-old male, diabetic for 8 years, presented with increased back pain, which he had for last 3 years. Now he has increased the severity, shock-like. Okay. As we due to time constraints, we are winding up the session. Thank you for patient listening.